Treating asthmatic and COPD patients is mostly pharmaceutical. Let's talk about using nebulizers to treat our bronchoconstrictive patients, and I'll show you my 4-part shortness of breath assessment. Hey everyone, my name's Steve, Paramedic Instructor Coordinator. Small volume nebulizers, or NEBs, are used to provide aerosolized medication to our patients in respiratory distress, caused mostly by bronchospasms such as those in asthma and COPD. Before we talk about setting up our nebulizer and administering our medication, let's go over our patient assessment so we make sure that we're giving the proper treatment to the right patient. As always, our assessment starts with meeting our patients. These patients are going to present with possibly a complaint of shortness of breath. You may see them in a tripoding position. They could be using accessory muscles such as shrugging their shoulders or having retractions. You could also have some audible breath sounds such as wheezing when you're walking in the room. These patients may also have low SpO2 readings and difficulty speaking between breaths. Getting lung sounds prior to administering our nebulizer will give us a good baseline for reassessment and will also help us confirm that this patient is having shortness of breath due to bronchospasms. There are 2 types of lung sounds that we're mostly looking for. One is going to be wheezing, the other one is rhonchi. Wheezing is caused by narrowing of the bronchioles due to inflammation, a lot of times seen in asthma and COPD patients. Typically described as a high-pitched whistling sound, it can be continuous, so that means it can be heard on inhalation and exhalation. Most often, you're going to hear it louder on exhalation. When wheezing is heard on inhalation and exhalation, this is what most people describe as a patient's chest being tight. Rhonchi, also described as coarse crackles, can be heard in patients with COPD, pneumonia, bronchitis, and is caused by inflammation and mucus buildup. It's described as a low-pitch, rattling noise, and is usually continuous as well. To remember rhonchi, I like to think of someone hawking up a loogie. Rhonchi! Diminished or absent lung sounds could also be present in our bronchoconstrictive patient, and this should lead us to concern. We need air movement in order to produce lung sounds. I like to remember 4 things when I'm assessing my shortness of breath patients. 1. Onset. How long has this patient been having their symptoms? 2. Word dyspnea. This is a good indication on how hard our patient is working to breathe. 3. Lung sounds. Not only do we want a baseline lung sound so we can use that for reevaluation, this can also help guide us towards making a decision on what could be the cause of their shortness of breath. And lastly, number 4, SpO2. If we can, try to get a baseline SpO2 prior to doing any treatments so that you have something to compare to. And then you can continue to use that SpO2 to reevaluate how beneficial your treatments have been. For our medication, we're going to be using a mixture of Albuterol and Ipratropium Bromide, or commonly called DuoNeb. Don't be confused though, as it comes in a similar package as just Albuterol. DuoNeb is going to have 2.5 milligrams of Albuterol and 0.5 milligrams of Ipratropium Bromide. Both Albuterol and Ipratropium Bromide work on the autonomic nervous system. That's that fight or flight, rest and digest. Albuterol is going to work on that fight or flight part of the autonomic nervous system and is what is called a beta-2 agonist. So that means it works on beta-2 receptors. And what it's going to do is help relax the constriction in the bronchioles, opening up that airway. It's fast acting and typically has an onset of less than 5 minutes, which is why it's commonly used in rescue inhalers. Ipratropium Bromide is an anticholinergic, and it acts on the autonomic nervous system by blocking that rest and digest. This is going to help by dilating the bronchioles, but mostly it's going to help us stop that mucus production that's often seen in COPD and asthma patients. Ipratropium Bromide has an onset of action that's a little bit longer than Albuterol, typically between 5 and 15 minutes, which is why, by itself, it's not often seen in a rescue inhaler, but most often in a daily maintenance inhaler. Combined, These two medications are going to attack our bronchoconstriction from two different sides of that autonomic nervous system and help us reduce that mucus production. Contraindications are going to include hypersensitivity to albuterol and Ipratropium Bromide. Patients who also have a hypersensitivity to atropine or any of its derivatives may have issues with Ipratropium Bromide as well. Let's go over assembling our nebulizer set. We have a few options. We have the nebulizer set, or we can use a nebulizer mask. We're going to need the medicine cup and chamber. We will need the T-piece, the reservoir tube, the mouthpiece, and the oxygen tubing. To assemble this, we'll start with the T-piece, and if you notice, one side is bigger than the other. Attach the reservoir tube, and grab the mouthpiece and attach it to the T-piece. Next, we'll separate the medicine cup and the chamber. Open the medication tube. And squirt the medication into the medication chamber. Put the cup and chamber back together and attach it to the T-piece.
Try to maintain the medicine cup in an upright position so the liquid doesn't fall out.
Then attach the oxygen tubing to the medication chamber. The oxygen will atomize the medication into a fine mist. The neb set helps the patient feel in control and is good for someone with mild to moderate shortness of breath. The patient also must be able to follow instructions. We can also replace the T-set with a mask. The neb mask is great for patients with more moderate to severe respiratory stress or those who can't follow instructions. Whether we're using a neb set or a mask, we want to make sure that we're setting our oxygen level between 6 and 8 liters per minute. This is because the size of the particulates of our medication is based on the flow rate of oxygen. Anything less than 5 liters per minute, that particulate is going to be too large to make its way down to the lower airways. Greater than 8 liters per minute, we're going to end up vaporizing our medication way too fast, and our patients are not going to get the benefit. If our patients require supplemental oxygen, we can always give them oxygen via the nasal cannula while we give them their neb treatment. One last thing that we need to make note of is wheezing in children under the age of 2. Typically, wheezing in children under the age of 2 is going to be due to bronchiolitis, which is a viral infection and not asthma. Bronchiolitis causes narrowing of the airways, but this is going to be a result of edema, not constriction. These patients may not always benefit from nebulizer treatments, but a trial period is appropriate. These patients can be treated with supplemental oxygen and maintenance of any nasal or oral secretions. To wrap up, guys, treating our COPD and asthma patients with nebulized treatments is going to be best. These conditions need to be treated with pharmaceutical means, not mechanical means. But remember, we need to make sure that we're assessing our patients and treating the right patient with the right medication. So, look for that onset, look for where it dips in you, get a good visual on their patient and what their degree of distress is. Always grab lung sounds so we have something to reevaluate and get an SpO2. Thanks guys for joining me and good luck out there. If you got any questions, please reach out.